Hello everyone. So today in this video we'll be discussing a few important points when you are discussing a thyroid case. So thyroid usually comes as a major case for ENT practical exams, and even in surgery also it can come. So in both the sides it is a case for the PG exam, and also in UG also it can come as a case for final exams in final year. So guys, some important points about thyroid. So first one, iodine deficiency. It is thyroid, one of the major causes because of the iodine deficiency. And iodine deficiency, it is commonly seen in interior and mountain areas, and mainly in the Vindhya Himalaya areas. And but goiter, which is the enlargement of the which is seen observed in the neck, so that is more common in South India. And follicular and anaplastic carcinoma, they are associated with iron deficiency. And simple goiter, which is seen in puberty in girls, it's normal. And physiological goiter, it is the one which is commonly seen in pregnancy and puberty. That is because of the hormonal changes, so there's nothing to worry with that. Next one, solitary nodule, colloid goiter, papillary carcinoma, and primary thyrotoxicosis, they are seen in the age group of 20 to 40 years. And multinodular goiter, follicular carcinoma of thyroid, and Hashimoto's thyroiditis, they are commonly seen in middle-aged women. So thyroid as such, it is more common in women, and the age groups are these. Then most of the times it presents as a swelling in front of the neck, and the duration, yes, the duration is very important while presenting the case. And I'll be coming up with a case itself in my next video where we'll be discussing about how to properly present a case itself. But these are some of the important points which can be asked or which are to be kept in mind while doing the case. So swelling along with the duration, and whether there is pain over the swelling, and if pain is there, then the duration of that, and is there any associated features like hoarseness of voice. So hoarseness of voice is mainly because of the compression of the recurrent laryngeal nerve. So many of the times students answer it as it is because of the infiltration of the recurrent laryngeal nerve. No, that is wrong, because that is very rare. The most common cause is because of the pressure symptoms, which causes the hoarseness of voice. Then hand tremors, so the hand tremors can be observed. And then difficulty in swallowing or breathing, that is again because of the pressure symptoms. And then generalized weakness can be there, and palpitations and loss of significant weight. So even loss of significant, all these are seen in case of goiter. Hyperthyroidism features like palpitation, generalized weakness, loss of significant weight, all of these are features of hyperthyroidism. And the features of hypothyroidism is usually opposite to that of the hyper. So sudden rapid increase in the size of the swelling is usually seen in case of malignancy, and in hemorrhage as well it can be seen. So whenever presenting the case of HOPI, a swelling has to be mentioned, the swelling along with the number of nodules, the number of swellings you can see, then the size of each of the swelling, then the duration and the progression, whether it is gradually progressive in size. So all those should be mentioned. And pain, again, duration, and then the character of the pain, whether it is dull aching type or pricking type, so the character, then the site of the pain and radiation, and also the associated factors should be mentioned. So usually the goiters are painless, but malignancy, it is initially painless in the initial stages, but later it can become painful. Then thyroiditis, it is painful, and whenever there is infiltration into the surrounding structures or necrosis or hemorrhage, it makes it painful and tender. Next, the pressure symptoms. Again, the symptoms like dysphagia, dyspnea, stridor, all these, it is because of the infiltration into the trachea. And hoarseness, as I said, it is because of the recurrent laryngeal nerve compression. And sometimes Horner syndrome can happen, which is because of the infiltration of the cervical sympathetic chain. And the four features of Horner syndrome, again, ptosis, then loss of sweating in the same side of the face, enophthalmos, and meiosis. So all these four, ptosis, anhidrosis, enophthalmosis and meiosis, all these will be seen. So again, pressure symptoms, whenever we describe, you have to say the duration, onset, progression. Then in thyrotoxic crisis, there can be pretibial mixed edema. So it is not the mixed edema which is of the hypothyroidism. This is pretibial mixed edema. So that is seen in case of hyperthyroidism, that is thyrotoxic crisis. Next, autoimmune thyroid disease. In this, we can see thyroid acropathy, which is shown by digital clubbing, swelling of digits and toes because of the periosteal reaction. Then BP may be high in toxic thyroid, and it should, whenever we are measuring BP, we have to mention which hand was used, and it is checked in which position of the patient, whether it is in supine or sitting. Which position also has to be mentioned. Then there's something called sleeping pulse rate, and this is checked for 3 consecutive days. The sleeping pulse of the patient is checked, and then the average is taken. So there's a classification for the sleeping pulse rate, that is the Kreil staging. So up to 90 pulse rate, it is grade 1, 90 to 110 is grade 2, and more than 110 is grade 3. Then fine tremors of the hand, it is usually seen in toxic thyroid because of the irritation of the gray matter in the brain, and tongue twitching can also be present in this patient. Then assessment of voice, we can do the indirect laryngoscopy or the video laryngoscopy, where we can see the movements of the vocal cord. Then moving on to the examination of the swelling. First, inspection. Again, the size, location, shape and extension should be mentioned. And extension, usually it is to the posterior border of the sternocleidomastoid to the midline. Okay, and upper extent is up to the thyroid cartilage, and lower margin is usually visible during deglutition. So if the lower margin it is not visible, then that means there is retrosternal extension. So next, thyroid moves upwards with deglutition as it is attached to the pretracheal fascia. Again, very important. Movement is because of the attachment to the pretracheal fascia, the Berry's ligament. And swellings which move upward with deglutition. This can be asked as a viva question. So one is the thyroid swelling. Next is the subhyoid bursa. Next is the thyroglossal cyst. Then pretracheal or prelaryngeal lymph nodes. Then any swelling from larynx or trachea can also move. Then occasions where thyroid swelling may not move with deglutition. So it is seen in case of anaplastic carcinoma of the thyroid gland, and then carcinoma thyroid with extensive invasion into the soft tissues, and intrathoracic retrosternal extension with infiltration or impaction. Also Riddle's thyroiditis with encasement of trachea, and massive thyroid wherein the movement upward is difficult to observe. Next, lymph nodes, they are commonly enlarged in case of papillary carcinoma of thyroid. So whenever we are suspecting papillary carcinoma, lymph nodes very important to check. Next, palpation. Temperature over the swelling, we have to check whether it is warm. So it is mostly warm in case of toxic thyroid malignancy and thyroiditis. Then tenderness, it is usually seen in case of hemorrhage, thyroiditis and tumor necrosis. Then extent again has to be mentioned, just like we did in inspection. Then size, shape and location of the swelling has to be mentioned. Then the surface and the consistency. So consistency, whether it is soft, firm or hard, should be mentioned. And margins, whether well defined or diffuse, should be mentioned. Then the lower margin of thyroid, is it felt or not felt? If it is not felt, then there is retrosternal extension. Again, a very important feature. So dilated necks over the vein or chest may be also seen when there is retrosternal extension. And normal resonant note is noted over the sternum. It becomes dull on percussion when there is retrosternal extension. So this resonant note over the sternum, it is not very reliable, because sometimes in normal people also it will be dull itself. So certain textbooks have mentioned it, standard books have mentioned it, but this is a little confusing matter about that. Even from the examiners, among the examiners, there's a confusion about that. Then certain signs like the Pemberton sign, it is positive in retrosternal goiter. So where you will be asking the patient to raise their hand and do the finger closing movement, and then there will be sudden flushing of the face, and all that will be seen in case of positive Pemberton sign, and that is seen in case of retrosternal goiter. Then the mobility of the swelling should also be checked, and whether the skin over the swelling is free or not. Then thrill, it is checked on the upper pole of the gland, as superior thyroid artery is superficial and enters the gland in front of the upper pole. So thrill signifies that there is toxicity or increased vascularity. Kreil's method, this is or swelling with the pulp of the finger. And then the other methods of examination, all the methods of examination of thyroid swelling, very important. The Spilzilo's method, it is used for short neck and obese individuals. Then the Lahey's method, the most commonly used method, it is used to palpate any nodules in the posterior part of the gland, and the commonly used one. Then cautious, it is used to check tracheal compression. So if there is any stridor present while doing the coccus test, it is a positive coccus test. So in case of long-standing thyroid or large goiter after thyroidectomy, there is no support to the trachea, and it can lead to tracheomalacia. So such patients, they need temporary tracheostomy after thyroidectomy for 2 to 3 weeks. To check for tracheal deviation, again tracheal deviation, a very important thing which we have to do. So again, the ring finger and the index finger are kept on the sternal head, and the middle finger is kept over the trachea, and the trachea is we try to move and move the middle finger to see the deviation of trachea. Then something very important is the trail sign. It is the prominence of the clavicular head of the sternocleidomastoid on one side. So there is absence of hollowness on the side of deviation in trail sign. And on auscultation, again, hearing of red sounds on the same side of deviation will be there. So all these are important signs in case of tracheal deviation. Next, carotid pulsations. They normally felt at the upper border of the thyroid cartilage over the medial aspect of sternocleidomastoid on the Kasich-Nack tubercle on the transverse process of C6 vertebra. So there is something called Berry sign, very important. So absent carotid pulsation in advanced carcinoma thyroid because of the infiltration of the carotid sheath by the tumor. Then sympathetic chain, it is involved in locally advanced thyroid carcinoma causing Horner's syndrome, as I've told. Enophthalmos is because of the weakened Muller's muscle, ptosis, anhidrosis, and meiosis. So meiosis is because of the paralysis of the dilator pupillae, and there can be absence of ciliospinal reflex, flushing of face, and nasal congestion, all seen in Horner's syndrome. Then lymph nodes, the lymph nodes level 3 and 4, they are palpable in papillary carcinoma of thyroid. We need to also check for any lateral aberrant thyroid in the neck. So again, very, very important. So they can appear as a lymph node and the lateral aberrant thyroid. So again, that has to be checked. Then percussion over the manubrium sterni. As I told, if it is dull, it signifies retrosternal extension, but still there is a little doubt about that. And tenderness may signify secondaries in the sternum from the follicular carcinoma of thyroid. So tenderness over sternum as well, we need to look. Then auscultation of the upper pole of the gland for Bruy is done. In toxic thyroid, severe cases and vascular tumors, it is positive. And in secondary thyrotoxicosis, cardiac compression is common, presenting with features like tachycardia, ectopic pulses, paradoxus, extrasystole, and atrial fibrillation. And secondaries and pleural effusion, they are seen in follicular carcinoma of thyroid. So hepatomegaly and secondaries in the liver, that is commonly associated with follicular carcinoma of thyroid. So liver and lungs both are affected in follicular carcinoma of thyroid, both have an association. And hepatomegaly can occur as a part of Graves' or Hashimoto's thyroiditis. Then secondaries to the bone is seen in follicular carcinoma of thyroid, commonly to the skull and to the rib. Then eye signs of hyperthyroidism, again very, very important. So von Graffi sign, which the Lidlac sign, that is the Lidlac sign. Then the Dalrymple sign, Stellwag, Geoffroy, Mbbs sign, Enroth sign, Rosenbach, Jelinek, Gifford, Glowey, Ney sign, Cohen sign, Kocher sign, Nafziger sign, Grove sign, Rokin sign, Boston sign, Mean sign, Griffith sign, Sainton sign, Vigorous sign, Ballot sign, Huker sign, Wilder sign, Trocheus sign, Opine sign, and Riesman sign, Snellens or Danter sign, and Goldziher sign. So all of these very, very important. All these signs, like I've tried to mention all the signs which are seen in hyperthyroidism. So please go through each of them. What is that? And very, very important. Then the order of appearance of signs. Stellwag sign comes first, then the von Graffi sign, then the Geoffroy, and then the Mbbs sign. Then exophthalmos, it is because of the infiltration of the retrobulbar tissues with fluid and round cells with visible lower bulbar sclera and lid spasm of the upper eyelid due to levator palpebrae superioris innervated by the sympathetic chain. And laryngocele, in case of laryngocele, there can be reducibility which is present. So the swelling will go inside. Reducibility means that swelling goes inside when pressed and comes out only with straining or coughing. So this is seen in case of hernia, meningocele, and varicocele. So these things are not related to thyroid, but a few related questions somewhere nearby. Examiners can just beat around the bush and ask these questions. So then compressibility, there's a difference between reducibility and compressibility. Compressibility means that the swelling can be pressed, but it does not go in completely. So this is seen in case of lymphangioma and hemangioma. Then fluid thrill is commonly seen in cystic hygroma. So these are all again neck swellings, but not the thyroid one. So the swelling which molds on palpation, that is sebaceous cyst or dermoid cyst. And fluctuation, again very, very important. We need to check if the swelling is fluctuating. Pseudo fluctuation is seen in large soft swellings, and cross fluctuation, it is fluctuation between two separate swellings communicating with each other. So this is seen in case of flunging ranula. Then transillumination test is again done in swellings, and it is positive in cystic hygroma and ranula. So swelling, again, if it is pulsatile or not has to be checked. Expansile pulsatile swelling is seen, or transmitted. So expansile means the fingers kept on the swelling are lifted and moved apart, and transmitted means the fingers are just lifted when kept above the swelling. So lymph node enlargements at each levels and differential diagnosis has to be mentioned when presenting a thyroid case, and also the ECOG score should be mentioned. That is also quite important, and Kanofsky performance status score. So these two are like most of the students don't mention, but if you are mentioning, it is it is good. And please read about ECOG and Kanofsky performance status score. Then branchial cyst, it is usually located deep to the anterior border of the sternocleidomastoid. The swelling does not become prominent on contraction of the sternocleidomastoid. It's a fluctuant swelling, and it changes in size. That is about the branchial cyst. Then swelling which changes in size on valsalva is the laryngocele. And in case of ectopic thyroid, which is presenting as a lateral neck swelling, it does not move on the protrusion of the tongue or deglutition. So investigations, USG is the first investigation. Then elastography is also nowadays very much done. It helps to find the consistency. If it is hard, then it is malignancy. Then FNAC, based on that, after FNAC, based on the Bethesda classification, surgery is usually planned. But some doctors, they directly take up for hemithyroidectomy, and then based on the frozen section, they decide on completion thyroidectomy. So apart from solitary thyroid nodule, all other thyroid nodular goiters, they require surgery, except for solitary thyroid nodule. The only nodule which does not require surgery as a compulsory thing. So all other thyroid nodular goiters, they require surgery. In hypothyroidism, there can be vocal cord edema which can cause alteration in the voice. And in recurrent laryngeal nerve compression, hoarseness of the voice can be present. So temper of the voice is affected by the superior branch of the external laryngeal nerve. It is nickname related to an opera singer, because the person had lost their job because of the loss of the temper in the voice. So again, the examiners can ask about how to check the water hammer pulse, and also where to palpate for the carotid pulse between the trachea and the sternocleidomastoid at the level of cricoid cartilage. Another important question is about the Delphian node and features of malignancy that can be seen in solitary thyroid nodule. They are irregular margins and scattered microcalcification. Again, scattered microcalcification is something very much favorite asked from the examiners. Then also we need to define a stridor. Again, a common question. What are the pressure symptoms in thyroid? The dysphagia or dyspnea, all those features I said. Again, the hoarseness of the voice because of the compression of the recurrent laryngeal nerve. All these are features of pressure symptoms in thyroid. So that's it, guys. I'll be coming up with my next video where we'll be discussing about a case itself about thyroid swelling. So that's it. Till I come back with my new video. Stay tuned. Till then, bye.